Good morning, colleagues, guests, and participants for today's webinar. It's a great pleasure to see so many of you have joined. Its title is Turning the Tide on Diabetes, Education, Action, and Policy for a Healthier South Africa. My name is Cara D. Wright, and I serve as the Deputy Chair of the Academy of Science of South Africa's Standing Committee on Health. And I'm also a Chief Specialist Scientist at the South African Medical Research Council in Pretoria. Thank you very much for joining us as we confront one of the most pressing and complex public health challenges of our time, diabetes. This disease continues to affect millions of South Africans and places a very heavy burden on individuals, families, our healthcare sector, as well as our economy. Today, we bring together a mixture of voices from lived experience and advocacy to research, policy, and public health economics to reflect on what it will be to take to truly change the trajectory of diabetes in our country. Together, we will explore how education, innovation, and evidence based policy can transform our national response to diabetes and to help build a healthier, more equitable future for all South Africans. We are honored to be joined today by three outstanding speakers who will help guide our thinking and also inspire our collective action. First, we have Mr. Siyabonga Kwanele Zuma, a passionate diabetes advocate who will share his personal journey and speak to the critical role of advocacy in shaping awareness and influencing policy. Next, we have Dr. Patrick Ngasa Piotti from the University of Pretoria and chairperson of the Diabetes Alliance South Africa, who will highlight innovations in diabetes care and the importance of community-engaged approaches. And last but not least, we have Professor Susan Goldstein from the SAMRC Wits Centre for Health Economics and Decision Science, Priceless, South Africa, who will discuss the broader implications of fiscal policy in prevention with a focus on South Africa's sugar tax. I invite you in the audience to listen closely, to ask your questions, and think critically about the roles that we can each play in addressing diabetes from our various spheres of influence. I would like to call on our first speaker, Mr. Siyabonga Kwanele Zuma, to take the stage, and we'll flight your slides now. Thank you.
Good morning, everyone. Thank you for having me today. Next slide, please. So my name is Siyabonga Kwanele Zuma, and I'm honored to join you here today all the way from Hawi, KwaZulu-Natal to share my journey of living with type 1 diabetes for the past 17 years. As a diabetes advocate, I am a father, a husband, and a poet who uses words to reflect on life, society, and the struggles that shape us. Diabetes has shaped my life in many ways, and I am here today to speak about the power of advocacy in shaping awareness and policy in the diabetes care and management. Next slide. I will start by sharing my story of living with diabetes for the past 17 years because I feel it is important for a diabetes advocate to share their lived experiences in platforms such as this. Imagine growing up in a household of two uneducated parents. My older sister was diagnosed with type 1 diabetes, and a few months later, in 2008, I was also diagnosed at the age of 11. I didn't know much about diabetes besides it being a disease that has to do with eating too much sugar or a disease for the elderly. It was something foreign to me. Next slide. All I remember was being told by doctors that my life had changed forever and that I would be taking insulin for the rest of my life. I didn't even know what insulin was, and having to inject it on my stomach was quite shocking. It scared me. I was told to take this much insulin before meals and this much before I go to bed. There was no real conversation about adjustments, no real guidance on how different factors affect glucose levels and no encouragement to actually take control of my own diabetes and make it my own responsibility. I didn't realize this at the time, but I didn't feel educated about diabetes at all. I didn't even understand how I got diabetes at my young age because it was believed that it's a disease for the elderly. Next slide. I didn't know the difference between type 1 and type 2 diabetes. I remember being told by my doctors that if I don't live a healthy lifestyle, I won't reach the age of 21 with functioning kidneys or even alive. Hearing those words instilled fear in me. I didn't see myself reaching the age of 21 alive because I didn't feel I was equipped enough to live the life I was expected to live in the to live. This, in the long run, led to me falling to what we call diabetes distress. So when I got into high school, I decided to keep my diabetes a secret from my friends, my teachers, my peers. And that impacted the way I manage my diabetes. I would not take my insulin or check my glucose levels during school hours. I neglected routine doctor appointments and I indulged in a lifestyle one shouldn't indulge in when living with diabetes. One can imagine how that is for someone who's living with diabetes. That's what we call the diabetes distress, and I was deep in it. Next slide. So that went on throughout high school and university, keeping my diabetes a secret. And then in 2020, the secret became a heavy load on my shoulders. I couldn't carry it anymore, and I was tired of living a double life. So I decided to let people know through a Facebook post that I had been living with type 1 diabetes for the past 12 years. I immediately felt a sense of relief, and I'm not kidding. I immediately felt a sense of relief physically and mentally. It really felt like there was a heavy load taken off of my shoulders. And that acceptance alone, over a decade later, led to me connecting with other people living with diabetes. It made me realize that there is actually education about diabetes, but we don't really pay attention to it, or maybe we are not. How can I put this? It's not put in front of our eyes as it should be, but I will get that into that in a second. So me connecting with people, with other people living with diabetes, made me feel a sense of belonging because they understand exactly what I was going through, and I saw that it's not something uncommon to experience what I was experiencing when it comes to diabetes. I no longer felt like I was the only one going through diabetes distress. I no longer felt like I was abnormal and different from my peers, like how I felt growing up. This led to me being educated about diabetes like I've never been educated before. For the next 2 years from 2020, which means in 2022, I learned more about diabetes than I learned in 12 years while living with it. That made me realize that I may have also played a role in not receiving the education I needed, as I've stated before, because I was not exposing myself to diabetes awareness programs such as this webinar right here. So from there on, I decided to start advocating for people living with diabetes, be more in people's faces so that I wouldn't see people going through what I was going through in my community. And in the long run, this led to me observing gaps in the diabetes care and management in South Africa. And when I speak about gaps in South Africa, I'm not only speaking about the governments, what they should and shouldn't be doing. I'm speaking about all of us who live in it, including myself. With diabetes being one of the leading causes of death in South Africa, we have to work together to alleviate that. Next slide. So I don't actually find the existing policies related to diabetes sufficient enough to meet what we call the 90-60-50 diabetes cascade, which is part of the National Strategic Plan for the Prevention and Control of Non-Communicable Diseases in South Africa. The cascade refers to the steps a person with diabetes takes from being unaware of their condition to receiving treatments and achieving control. It highlights the gaps and the unmet needs within the healthcare system in managing diabetes, from screening and diagnosis to treatment and control. It aims to improve diabetes care by ensuring that 90% of adults are diagnosed, 60% of those diagnosed receive treatments, and 50% of individuals receiving treatments actually have controlled glucose levels. This cascade was discussed in detail at the 2023 Diabetes Alliance, at the 2023 Diabetes Summit, which was organized by the Diabetes Alliance South Africa. Next slide. So I think it's pretty clear that we cannot meet these targets if we don't work together, which is why I said when speaking about gaps I observed in the diabetes care and management, I'm not only speaking about the government, but those who live in South Africa. We should all see ourselves as stakeholders in this fight against diabetes. I, as a diabetes advocate, and other diabetes advocates, our job is to advocate for better access to care and resources, which in the long run should influence policy changes. As the saying goes, nothing about us without us. We raise awareness as much as possible in our respective communities, but we can only go far. We empower the public with our knowledge gained through lived experiences, workshops, and webinars such as this. So when people see us speaking about our lived experiences like I'm doing so right now, they gain the courage to actually take steps in helping us meet the 90-60-50 diabetes cascade targets. One can gain the courage to go for screening, whether there are risk factors or diabetes risk factors or not. One can commit to changing their lifestyle and taking their medication to keep their diabetes controlled. This will lead to more people living with diabetes and have controlled glucose levels. So if you pay attention, I was actually giving you a practical example of what the 90-60-50 diabetes cascade is trying to achieve. Next slide. So when I speak about doctors and healthcare professionals now, they play a crucial role in shaping awareness and policy. They can help people with diabetes feel empowered rather than restricted. Because when a patient feels restricted, they don't feel like they have a choice. They don't have a voice, even a choice in decisions made by healthcare professionals and policymakers in their diabetes care and management. For example, like how I said, I was told, take this much insulin, and then later I was told if I don't live a healthy lifestyle, I won't reach the age of 21 with functioning kidneys or alive. That strips me off my control. Not to say they were not telling me the truth, but the manner of delivery plays a very important role. So we shouldn't take that lightly. So instead of just prescribing fixed insulin doses, imagine how much of a difference it would make if every person with diabetes was taught one, how different lifestyle factors affect diabetes management and care, how to make small insulin adjustments to prevent highs and lows. This may be more related to type 1 diabetes when I speak about insulin. And also how to recognize the signs that the insulin doses need to change. Because it's not only about how you take your insulin, it's also about what you're going through in your day-to-day basis, stress levels, the weather. There's a lot of factors that come into play that we are really not taught about. I won't say we are not taught about. Education is out there. Education is out there. It's just us who have to make it We have to seek it. And while we are seeking it, we also have to have how can I put it? We also have to have efforts from the policymakers' side to make it easy for us to actually reach that education. So because many people with diabetes don't need more education, they need more guidance, knowledge, and understanding. Next slide. So in conclusion, as a diabetes advocate, I've observed a huge gap in efforts to meet the 90-60-50 diabetes cascade targets as a country. I believe that it's time South Africa establishes a nationwide diabetes awareness program, such as the one that was established for HIV decades ago. If you look at the state of HIV now compared to when it was how it was 2 decades ago, there's been huge amounts of progress that's happening, and that's because of the nationwide awareness drive that's currently happening, that's been happening for decades. So I feel like it's time to give diabetes the same treatments, as it has become one of the leading causes of death in South Africa. I'm not sure if people are aware of that or not, but it actually is. So when establishing these policies, policymakers should keep the cascade in mind, the 90-60-50 diabetes cascade. Every policy should contribute to meeting the targets. Advocacy plays a crucial role in influencing policy changes. Therefore, I believe we should also be included in decision-making process. We should be in the same rooms discussing policies that affect people like us who are living with diabetes, because we know how it is to actually live with diabetes, how we know how we are being treated by our country, by our people, by our healthcare professionals, and if it's working or not. So as the saying goes, nothing for us without us. So it's time that we are included. Next slide. Together we can do plenty and not feel empty. Thank you.
Thank you very much, Mr. Zuma. I really appreciate those words. You've shared a very personal story, and yet at the same time shown how deeply you are willing to go to advocate to try and solve the challenges behind this disease. So thank you. That was a very powerful testimony, and we are very grateful. I would now like to invite Dr. Patrick Ngasapiotti, a public health specialist scientist with over a decade of research and project management experience, to come to the center of our stage and flash your slides. Thank you.
Okay. Thank you very much, Prof. Kavadi, for the introduction and the invitation this morning. I'm just putting the slide in slideshow mode. Thank you. Yes, it's indeed a pleasure to be part of this very important meeting webinar this morning. I would like first of all to salute the Academy of Science South Africa for this initiative. It's really should be commended, and I would like to thank all the people who have contributed to the organization. It's a challenge to come after such a passionate and strong plea from Siyabonga, and I'm sure it didn't fall on deaf ears. My talk this morning will be, as you've seen in next slides, just to crystallize the conversation. First of all, allow me to make a short introduction. I'm Dr. Patrick Ngasapiotti. Indeed, I'm affiliated at the University of Pretoria, but I'm also the chairperson of the Diabetes Alliance in South Africa, which is a patient organization working for the rights of people with diabetes in South Africa. The University of Pretoria Diabetes Research Center was established a couple of years now obviously as a response to this crisis that we are experiencing in the country when it comes to diabetes. It's organized around various clusters, as you can see on the slide. One of our flagship project has been the Swane Insulin Project. However, we are permanently seeking new partnerships and collaboration to really address this crisis of diabetes, not only from the research side, but also with advocacy and policy influence. Indeed, my talk this morning is titled Innovating for Equity in Diabetes Care, Lessons from Research, Policy and Community Engagement. I would like to start with a short quote that I found in the Lancet 2 years ago. It says that diabetes is a defining disease of the 21st century. How the health community deals with diabetes in the next 2 decades will shape population health and life expectancy for the next 80 years. The world has failed to understand the social nature of diabetes and underestimated the true scale and threat the disease poses. Listening to Siyabonga and being involved in diabetes for a couple of years now, I believe that this quote is also true not only in South Africa but also on the African continent. It is therefore important that we change course and react accordingly to really avert not only a high number of deaths but also preventable suffering. Siyabonga mentioned it. I will just bring to you the data. Indeed, according to StatSA statistics released in 2024, diabetes can be now ranked the #1 cause of death in the country, way ahead of HIV and probably tuberculosis as well. You can see on the graph that there have been years where COVID was the #1 cause, but we knew that was just not a permanent situation. As we know, the COVID-19 pandemic has now rescinded. So indeed, diabetes is the leading cause of death, sometimes characterized as leading cause among women, but the bad news is both men and women. Therefore, we need to act and act now. As I made the case for the urgency of action, is because of we're dealing with a growing crisis and this unfortunately stark glaring inequities when it comes to diabetes in South Africa. Already we have high prevalence, about 12%, estimated about 4.3 million to sometimes even 5+ million South African living with diabetes. Unfortunately, half of them are undiagnosed. So this means, as Siyabonga said, we need to work more in terms of awareness. We have 67% of the population that is pre-diabetic. That is according to our GHS results. And you know, we're all aware of, unfortunately, the high burden of overweight and obesity that we are experiencing in South Africa. All those risk factors, all that context is really setting the scene for a devastating crisis if actions is not taken and taken now. Just to position the crisis of diabetes within the African region, it's indeed in South Africa, we have the fastest growth when it comes to diabetes. You can see here, based on this data from 2015 and 2021, that there is a conclusion we can make. South Africa rates exceeded other sub-Saharan countries by 3 to 5%, having a prevalence double just in 6 years. Indeed, actions is needed. We here can see the prevalence projections based on the International Diabetes Federation. You can see we are estimated at about 4.2 million in 2021, but it's almost set to double by 2045 if appropriate action and interventions are not implemented. Just to not assuming that everybody in the audience is familiar with diabetes, it is important that we differentiate the types of diabetes, but quickly here, we usually have type 1 diabetes diagnosed at a younger age, as it was the case for Siabonga and many other thousands of South Africans, but it represents 5 to 10% of all cases. In general, when people talk diabetes, they are most likely to refer to type 2 diabetes, which affect 90 to 95% of the population. And that's in that group that we are seeing a vast or rapid increase. Although also in South Africa and globally, there's been also an increase in cases in type 1 diabetes. Then we have gestational diabetes. That's a specific a form of diabetes that occur during pregnancy. We are therefore talking here about women. The importance of gestational diabetes is that women who develop gestational diabetes or diabetes during their pregnancy are at an increased risk to develop type 2 diabetes later in their lives. And that risk also applies to the child, the child or the children that they were carrying during that pregnancy. Therefore, it's important that those women are monitored and that intervention are put in place so that we can prevent them from reaching type 2 diabetes. We can also describe other type of diabetes. For example, recently type 5 has been recognized by the International Diabetes Federation, but I won't take much time on it since this represents really the bulk, and that's where the public health significance lies mostly in type 1, type 2, and gestational diabetes. As I continue, I would like to really say a few words in terms of debunking the narrative of diabetes being a lifestyle disease. You might have heard that many times. It's a narrative, unfortunately, that tends to finger point, that tends to blame the individual. And I want to really make the point that a lot of factors that are linked to or that are contributing to an individual eventually developing type 2 diabetes are for the most part within or without or beyond, should I say, the reach of that individual. You can see on the image here, for example, food environment, for example, the way we design our cities, the ability, the capacity or ability to exercise within our cities. We go to work early in the morning, we come back late. Some of us have to go long distance because of the urban planning, the legacy of the past, and obviously education that Siabonga was mentioning, growing up in a family with people who haven't received long years of education is also a factor. All those aspects, you'll agree with me, cannot be put at the foot of the person living with diabetes. This is a societal challenge. That's how I believe it should be framed. Therefore, we need to shift our perspective from an individual to a societal perspective if we are to address the challenge of diabetes. The social determinants are here. They are very clear. Housing condition, food access, education, community safety. For example, the ability to go out at night to have a jog. We know very well that none of us will recommend that to anybody but his enemy. So therefore, we have to change our mindset as a country, as individuals, to understand that addressing diabetes will take a societal approach, a societal perspective in South Africa. In terms of equity gaps, what it looks like when we're talking diabetes, we obviously talking about late diagnosis. Because of that low level of literacy, people are not able to identify the warning signs. The level of awareness is low. There's limited access to care and also poor continuity of care in our health system that are not only overstretched and overburdened, but also somehow archaic in the sense that we are still relying on the paper-based system. We have nurses and doctors rotating, some of them leaving the employed to seek better opportunities. As a result, the person living with diabetes found himself disempowered in the middle of a health system that they seldom understand. Therefore, it's important that those equity gaps be addressed. We have not only the disparities between obviously urban and rural. This is typical to most African countries where most resources are available in the urban sector. In South Africa, you can even bring a further layer of disparities where you have the private sector and the public sector. But we also obviously have the challenges that people from previously disadvantaged communities are going through. As a result, vulnerable groups and population are left behind when we talk about diabetes, and that needs to be addressed. If you are to just look at quickly the research driven of innovation that is occurring at the center at the University of Pretoria, we, for example, spearheaded the Swane Insulin Project between 2019 and 2023. It was an innovative community-based intervention where nurses and community health workers were empowered to assist people with type 2 diabetes as they transition from oral drug to insulin. It was a successful intervention where we brought in a bit of digital health, a bit of education of the patient with a 14 weeks monitoring, and we managed to achieve tremendous outcome with the reductions of HbA1c in those participants. We can mention another innovative initiative with the diabetes retinopathy screening that we ran in Swane. You should understand that people living with diabetes unfortunately have their eyes affected by the high levels of sugar in their blood, and that test that should be available to screen for the retinopathy damages, unfortunately is not available as a routine in the public sector. So we had a small pilot where we put a fundus camera in one of the community healthcare center. We trained the people at the diabetes clinic, the eye clinic there, and using AI, we were able to screen a certain number of patients. Really, our call here is that blindness is preventable from diabetes when we detect early, and there should be an intervention available for those so many people that we say are living with diabetes in South Africa. Furthermore, in terms of research, I can mention this current initiative. Siabonga spoke of his experience with type 1 diabetes, the inability of the health system to respond adequately to this challenge. The fact that at first we are unable to decide or to pinpoint where the people living with type 1 diabetes reside. Where are those diagnoses made? Where are the needs? There is really a blindness when it comes to the data available in this aspect. Therefore, with the University of Pretoria and Stellenbosch University, University of Cape Town, University of KwaZulu-Natal, Wits University, and University of the Free State, we are coming together to run this study so that we are able to have accurate national data for type 1 diabetes. It's really an opportunity also for me to call upon anybody listening or who is either living with type 1 diabetes or a family member of people with type 1 diabetes to go to the University of Pretoria Diabetes Research Center website. You'll find the landing page there. All information are available and also how you can contribute. We believe that if the community of people with type 1 diabetes can volunteer their data all over the country, we will be able to have to build the map of type 1 diabetes and therefore inform policy and action in the country. Other initiative at the university is the fact that we are building a biobank and longitudinal cohort for diabetes. These are really groundbreaking, innovative research happening, as well as a focus on gestational diabetes, as I previously mentioned. In terms of turning research into policy, yes, we are researchers and we dedicated our life to do those research, but it's important that we understand that it shouldn't end just with the publication of an article. Those findings should be translated into policy through advocacy and other means. And in the coming slide, I'll just describe some of the efforts. My colleague will speak lengthily about the sugar tax revenue after me. I won't therefore be spending much time. The National Strategic Plan that Siabonga mentioned, you might want to have a look at it, find it on the internet and read it. It's very important. For the first time, we have a target for diabetes and hypertension in South Africa. It says that 90% of people over 18 years old should know whether they have diabetes or hypertension. 60% of them should receive some sort of intervention, and 50% of those receiving intervention should be controlled. As it is now, we are sitting with dismal control level, whereby it's less than 20% of people living with diabetes on treatment who are achieving control. Whether they are accessing care in the private or in the public sector is therefore a crisis and a challenge that we should, as a society, respond to and address. Quick words about the 2023 Diabetes Summit that Siabonga mentioned. The theme was Diabetes Target Translating Policy into Reality. It was really, as the Diabetes Alliance, to understand that the Department of Health alone cannot achieve the diabetes target. We need a whole of society approach. Therefore, the summit was a platform where all organizations involved in diabetes, interested parties, people living with diabetes came together to debate and to discuss how these targets can be attained. We produced a report, and I'm just showing you some snippets. For example, in terms of education, what were the challenges? The fact that there's no standardized education program, there's no diabetes nurse educator available in the country. For example, in terms of management and access to care, the provision of medication is a challenge sometimes, as well as monitoring tools. We have a suboptimal control of people living with diabetes. That is a big challenge. In terms of surveillance, we don't have access to accurate data in South Africa when it comes to diabetes. We are thumb-sucking, we are using estimates, but we are unable to pinpoint exactly where the people are, when are they diagnosed, how are they faring, so that we can respond optimally to such a crisis. This report was handed over to the National Department of Health. As you can see, you have a QR code on the slide. If you scan it, you will have access to the report yourself. For your knowledge, and also we call on all of us to become advocates, because we know diabetes affecting you, it's affecting me, it's in our families, and it's sometimes our children, our parents. We need to all come together to respond to this crisis. The community-led angle that I would like to mention this morning in terms of the Diabetes Alliance, acknowledging the impact that diabetes has on individuals and on communities, we decided to promote what we call Diabetes Alliance chapters. These are subdivisions of the Diabetes Alliance that will be located in various provinces. It's about driving a grassroots movement around diabetes. If you're a person living with diabetes, if you're a family member of a person living with diabetes, please go to the Diabetes Alliance website for further information. Reach out to us. We are there to listen to you and how we can work together. These chapters will therefore be a platform on which we build various initiatives. For example, we drive awareness, we drive education with the community wellness circles. And the last word that I want to say when it comes to community-led engagement, and I'm glad that Siabonga mentioned it, is the mental health aspect. People living with diabetes are at a high increased risk of developing depression and anxiety compared to the normal population. There is a big risk there, even with suicide and others. It's important that we recognize them as whole persons and that those issues are addressed. In the University of Pretoria Diabetes Research Center, we are working towards initiating research and advocating for the mental health of people living with diabetes to be integrated into routine care. In terms of what Siabongas mentioned, the importance of involving people living with diabetes, there have been many innovations that are in the diabetes space. Unfortunately, South Africa is not leading on that. We can mention, for example, the continuous glucose monitoring devices. These are devices easy to use that allow people living with diabetes to monitor their blood sugar levels without having to prick their fingers 4, 5, 6, 7 times a day. You can imagine if you are 2 years old, if you are needed to monitor your child, it becomes a huge nightmare. We are advocating for those devices to be available and accessible to the majority of the people who needs it in South Africa. Education needs to be decentralized. Yes, Siabonga says that materials are available out there, but the delivery thereof of diabetes education is not systematic, meaning that if you are diagnosed with diabetes in a certain region of South Africa, nothing guaranteed that you will receive the education that you need to be empowered, to be in control, and to take charge of your own condition. We need more person-centered models. And yes, we agree, the lived experience, people such as Siyabonga and diabetes advocate, people living with the condition should be at the center. And once you associate them with science and policy, that's when you arrive at sustainable solutions. Therefore, in conclusion, I really want to make a plea for us to leverage on existing tools. For example, the Health Promotion Levy, that was one of the recommendations of the 2023 Diabetes Summit, whereby this tax that is taken from the people should be reinvested towards prevention and management of diabetes and other NCDs. We need to work towards scaling the locally proven intervention, strengthening our primary healthcare system, because that's where most people living with diabetes are accessing care. Obviously, introducing psychosocial and mental health support. But at the end of the day, we need to support the civil society organization. We've seen the example with the HIV response. Our civil society treatment action campaign and others have really led the fight in this in the response to diabetes, to HIV. This should be the same with diabetes. And my parting word is really to announce that this year we're going to have the 2025 Diabetes Summit from the 5th to the 7th of November 2025. We will be communicating broadly. We are hoping to partner strongly with the Academy of Science South Africa on this event because, as we say, it's a whole of society response. Every partner is welcome. We need to come all together to discuss how do we innovate for impact in order to transform the future of diabetes in South Africa. I thank you very much for this opportunity. This is an email where you can reach out to me, and thank you again for your attention.
Thank you very much, Dr. Pioti. That was a extremely interesting and also concerning presentation in terms of the current situation that we are facing in South Africa, but definitely with many clear aspects that we can engage in together to find the solutions to solve these very big challenges. Thank you. I'm very pleased to now call upon Professor Susan Goldstein, who is a public health medicine specialist and divisional director at the SAMRC Centre for Health Economics and Decision Science, Priceless, South Africa. And I would like to hand over to Prof. Goldstein to help us understand better the sugar tax. Thank you.
Thank you very much. It's really a privilege to follow such great talks. And I need to recognize that the lived experience is so important as well as the clinical aspect. I'm going to pivot completely and talk about upstream prevention. And the main focus will be around type 2 diabetes and prevention of obesity. I also want to declare that I have no conflict of interest. And I want to just also notice that added to the social determinants of health, I'd like us to think about the commercial determinants of health, and that will come a little bit later. So there is a nutrition transition in South Africa. 25% of children, 26% under 5 experience stunting. 28% of households report food insecurity. And I noticed in the chat, somebody was talking about a child diagnosed with diabetes who only eats bread. South Africa also ranks number 7 globally for per capita sugar consumption. And SSB, that's sugary beverage consumption, in rural areas doubled from 2005 to 2010. So things are increasing. Poor nutrition fuels non-communicable diseases and strains health systems. So that's just the little bit of background. Just to remind people around COVID, prevalence of comorbid conditions for COVID during the epidemic. And if you look at the blue part, that's the non-communicable diseases with comorbidities. The red is HIV and the green is TB. So non-communicable diseases are not only important for themselves, but in how they also relate to communicable diseases. And sugar is a major NCD risk factor. And in particular, that in liquid form, it's an important cause of increased risk of obesity, diabetes, hypertension, cardiovascular disease, cancer, and dental decay. WHO and the World Cancer Research Fund published guidelines to say that we should have no more than 10% of our total calories from added sugar, and really ideally less than 5%, which is about 12% of 12 teaspoons maximum per day. And if you look at a 500 ml bottle of regular soft drinks, they contain 13 teaspoons. So we're talking about one 500 ml drink a day is your entire sugar load that you should be experiencing. In fact, more than. South African context. So the SSB consumption is linked, and I'm going to call sugary beverages SSBs, by the way. The consumption is linked to 20% of obesity increases, and diabetes-related deaths are about 30,000 annually. I'm not going to repeat, colleagues have already said that. But SSB intake is linked to 30% higher diabetes risk, especially in low-income groups. One of the points that Dr. Priotis mentioned was the healthy food available. This is a study that was done and looked at healthy food outlets in the Greater Johannesburg region. And all those little dots that you can see are where the healthy food outlets are in the center, and where there are the most deprived areas, which are the darker green ones, there are almost none healthy food outlets. So it's a little bit shocking. Obesity in South Africa. So the consequence of all this is that South Africa is second globally for a rapid increase in childhood obesity. There are approximately 16,000 deaths from diabetes due to high BMI. So there are more deaths from diabetes, but these particular ones are due to having a high BMI. 31% of adults are currently obese. And if you look at the NCDs due to high BMI in adults in 2019, the light blue is diabetes. Cancers, the green, stroke is red, and coronary heart disease is orange. Also, obesity in South Africa is growing. For women, we're up to 42% in 2023, 42% of women. For men, it's a little bit lower, but we're still 25%. That means a quarter of men are obese. What are the important drivers? We've already talked about the poor food environment, urbanization and sedentary lifestyles. But the problem is that obesity is costing South Africa 33 billion rand annually. That is about 2% of the GDP, and I'll come back again to that cost. The South African political environment around obesity and sugary beverages is that there's low advertising costs and poor regulation. The industry that I'm talking about, multinational industries often, but others, but multinational industries are shifting their focus to emerging economies where they see bigger markets. The sugary beverage market grew 20% in the SADC region from 2015 to 2023, and South Africa is a key exporter. So we're sending our bad sugary beverages through the SADC. And this area where I talked about the commercial determinants, there's such conflict of interest between the regulators, government officials, industries. There's regulatory capture. So, for example, the SSB tax, the HPL we call it, hasn't been increased since its introduction, and it was introduced at an inadequate level already. And the industry funds research, which makes it look as if we are not telling the truth as scientists. There's also a lack of policy coherence between public health goals and economic growth. So the DTIC would like more and more sugary beverage industry, while of course public health wants less. The costs, this is just an illustration. We worked out the costs of diabetes to be between 2.7 and 21 billion rand per annum. So we're talking about 12.8 and 50.3 billion rand every year, the cost of obesity, just from diabetes and hypertension-related illnesses. So what are the cost-effective interventions? Policies for healthier food and beverage products are important. Front-of-pack labeling so that people know exactly what is in their foods, and warning labels in particular. This policy is sitting at the Department of Health as we speak, and we hope that it's going to be enacted fairly soon. Taxes, as we talked about, the sugary beverage tax. Public food procurement. So in a public context, in a public place, we can find lots of sugary beverages, very poor quality of food, and that has to change. Government should not be providing poor quality food. Behavior change communication, and this has been mentioned a few times, particularly around diabetes, but it also needs to be used about how people can not get obese if possible, but with the caveat that it is largely environmental. We need policies to protect children from the harmful impact of marketing of these harmful foods. And we need protection and promotion and support of optimal breastfeeding practices. People forget that breastfeeding, obesity actually often starts pre-conception or at conception. So what I mentioned earlier of the cost of inaction, that means that the taxes of sugary beverages hasn't increased as it should have over the period since it was first introduced in 2018. And the soft drinks sales were predicted to grow by 2.4%. That was 2012 to 17. And the industry very clearly mentioned that they are targeting lower LSMs, so lower living standard, people in the poorer communities. And they see this as the main market opportunity. If you look on your right of the slide, 70% of where they want to target their sales is in the lower socioeconomic groups. So what does it mean? We've worked out what the cost of not having a 20% health promotion levy is. That if we had a 20% health promotion levy since 2018, we could have averted 619,000 cases of diabetes. And we could have averted 289,000 prevalent cases and 26,000 deaths. And we would have saved 23.9 billion in healthcare costs. This is compared to what we have at the moment at an 11% health promotion levy. We've also had a look at, because what happens is the industry have said, well, the health promotion levy is not doing anything. So what we've done is we've had a look at whether it is effective. And what we have found, that there have been increases in prices of taxable beverages. There's been reduction in purchase and content and container size. National household purchases of taxable beverages post HPL introduction in 2018 fell by 51% in volume and sugar intake by 29%. In year one, there were 3.2 billion rands in revenue, which was about 0.5% of total government revenue. And in the 2018 over the period that we've had, basically until 2024, that we've had the tax, we have accrued 15.1 billion rands. But what's important, the industry kept on saying, well, the sugar industry is collapsing and this tax has caused a decrease in employment. And our research shows that there has been no effect on employment over this period of time. So just to emphasize again what the population levels intervention are to reduce overweight and obesity, and that they are urgent. So increasing the taxation on sugary beverages to a level of 20%, restricting marketing and advertising, including the labeling of front-of-pack children, campaigns to promote healthy eating and norms among school children and removing obesogenic influences, and then access technologies to identify best buys. And if we don't do that, NHI will be too costly to introduce. We have to prioritize reducing overweight and obesity. And I'm not going to repeat the costs again, but our call to action really is, these are the key messages: to expand the HPL to 20% and include fruit juices, which are also very high in sugar, regulate food environments, advertising, and increase access to healthy food. And just to finally finish off, a recent article showed that a 50% increase in real prices of tobacco, alcohol, and sugary beverages would save 50 million lives globally over 50 years. That is not insignificant. And I thank you for listening.
Thank you very much, Professor Susan Goldstein, for a sobering presentation of facts and, of course, some very real concerns that even the policy that we have and the policy that we're strengthening is going to help, but will need really proactive implementation. So thank you very much for sharing this with us today. We are now turning to a time where we can have some questions and answers. And I encourage all of our participants, there are almost 70 of you in the room today. It would be wonderful if you could put your questions into the chat, and I will facilitate the asking of those questions. Of course, you're also welcome to put them into the chat box, or the Q&A, either of those will work. While I wait for one or two questions to pop up, just to note that there are a couple of links in the chat at the moment. For example, for Siyabonga's YouTube site, I would encourage you to go and have a look and subscribe. Then there's also a plea, please, if you want CPD accreditation certificate for this event today, please email Kutso. The email address is there. We've also put a link to the Diabetes Alliance that Dr. Pioti was telling us about. And if anyone would like to share any other things in this link, in this chat, please go ahead and do so. So we have a Q&A question from Kathy Haldani, and it's for you, Professor Goldstein. Do we know how the 12 billion rand from the HPL has been spent? Over to you.
Thanks very much. Well, what happens to that money from the HPL is that it goes into the greater fiscus. So there's very little, it's not earmarked at all. In the first year, they did earmark a certain amount. It was a small amount, a couple of million rand. But the Department of Health was not even able to spend that. And so they supported the Cancer Alliance. But that's it's our only knowledge of what has been spent. The rest went into the greater treasury. So I think what's important is to talk about, and what Dr. Pioti is advocating for, is that this money is earmarked towards prevention programs. And I think that for me, we've got to try and persuade Treasury to do that. They are prepared to what they call soft earmark, which means that they will earmark some money, but not permanently. So you won't definitely get that money. It depends on how good the fiscus is at the time. So I think that is definitely something that we need to advocate for.
Thank you very much. I'd like to now hand over to Dr. Pioti, please, for a response.
No, thank you, Prof. Indeed, I would like to concur with what Prof. Su just said. From what we heard from good source during the 2020 Diabetes Summit, is that less than 1% of that money has been directed towards the Department of Health for use within the NCD program. And indeed, that is a shame because in our interaction with the department, one of the complaints that we are hearing is that there's no funding. And indeed, what Professor is true that even that the little less than 1% that was sent to them wasn't used. And we really think that is unacceptable. There's so many needs when you look at the diabetes and NCDs in the country. Therefore, all cents are needed. So we really advocate for more. And there was an initiative recently, a group of civil society organizations have sent a letter to the Minister of Finance to request for a proper earmarking for a good chunk of those funds to be dedicated to NCD response in South Africa. We hope that the department, the Minister of Finance, will be reacting and that they are listening. Thank you.
Thank you very much. Yes, and Kathy has also acknowledged in the chat that we do need to advocate for this funding to be allocated back to health promotion, prevention, and access to innovation to close this equity gap. Thank you very much. There is a comment now. Thank you, Namagugu. This is a comment in the chat. Very sobering to hear when you realize that we have heavy health spend on curative versus preventative. Public education is so key. Are there any programs led by the Department of Health with the Department of Education to raise awareness in schools, for example, or are we still responding as silos? Thank you. That's a very interesting question. Um, uh, Dr. Pierti, would you like to go ahead? And then I'll call on Mr. Siabonga if you would also like to comment, please.
Yes, we are aware of the school education program. We don't know to which extent this has been efficient. We believe we can do more. A condition like diabetes, why not even teach the basic symptoms to the kids? It's easy to understand. Songs could be written even about it. So I'm sure kids will be able to drive information back in their homes. So, yes, we think the two departments should be discussing. That's why we are hoping to see them at the end of the year when we're having the diabetes summit, because education is a critical department when it comes to the response, the diabetes response in South Africa. We need to see more public awareness, as Siabonga said, and more education. There shouldn't be a South African who doesn't know about the basic symptoms of diabetes in South Africa. Thank you.
Thank you very much. Yes, over to you, please, Mr. Siabonga, to add your voice.
Yes, so to comment on the question that is there any partnership between the Department of Health and Department of Education to raise awareness about diabetes in schools? I don't know about the rest of South Africa, but in KZN, I don't believe so, because I even took it upon myself as a diabetes advocate to go around schools in my community raising awareness about diabetes. I would approach the schools myself and they would give me the platform. I would be there for a day or even a week, either on assembly or going class to class, teaching the kids about, not just the kids, but also the teachers. I would focus on identifying the 5 symptoms of diabetes. I would explain to them what's the difference between type 1 and type 2 diabetes. I would explain to them that it's not really, as Dr. Petrus Nasapiota said, it's not really, how can I put it? It's not really a lifestyle disease, because that leads to stigma. So I was telling them, I was teaching them about stigmas. What are stigmas? And how to identify stigmas and know the difference between stigmas and factual proof about diabetes. So I took it upon myself. I did that. And I would say it actually helped a lot, because sometime I will be walking down the streets or driving at a shop, and maybe kids will be like, oh, it's that guy, the diabetes guy. They would identify me as the diabetes guy. And I know for a fact that they also told their siblings or their family at home, because when I went to another school, there's a kid who asked me if I was at another school the other day, and I said yes. How do you know? And they were like, my brother told me that you were there and told them about diabetes. So I really think it's time we have, as I said in my presentation, it's time we have a nationwide awareness program directed to diabetes. Thank you.
Thank you very much for your responses. I appreciate the engagement and very truthful and sobering again comments. Thank you. There's a comment in the chat from Rian Norder, who says, mental health in men and diabetes. What is the statistics in death due to suicide if stats are available? The stigma with mental health is real with men, causing men to keep silent in general. Any advocacy plans to break this stigma, which is what we were just talking about? Yes, Professor Sue Goldstein, please go ahead.
I just wanted to comment. I don't have the stats on that. I apologize for that. But I think that health and men in general needs to be looked at very carefully, because men tend to not go for healthcare in general. There's huge stigmatization around attending health facilities, and mental health specifically. I agree with you. But I really think that we need to be looking again also at stigmatization in general, because I mean, we know about HIV and stigma. It still exists, by the way. We know about diabetes and stigma, obesity and stigma. So I think that what we haven't got is a general health literacy program, really, which needs to be in schools. This needs to be driven at a national level and at provincial level in schools, really understanding how people's bodies work, that illness is not something that people can control necessarily, and that lifestyle is not as important as you say, Siyabonga, as you say, as the environment that we live in. And you know, so for me, there's a lot of education that needs to happen around health literacy, and I think that unless we do that, we're going to keep on working in silos and not really get to the nub of the problem.
Apologies, I had a moment there. I needed to unmute. Thank you. Yes, I agree. I think that there's a lot of work that still needs to be done. Dr. Purity, would you like to add anything?
Before I say anything, please, Prof, allow me. There's a hand raised by Mr. Itumeleng. It's at the Department of Health, NCD Department Division. So I believe it's only appropriate if we give him an opportunity to speak.
Thank you for spotting that. I appreciate that. I did not see the hand raised. Please go ahead, Dr. Itumeleng.
Good afternoon and thanks. Yeah, my name is Itumeleng Setlare from National Department of Health. I'm coordinating chronic diseases, and thanks for the enlightening presentations. I just wanted to comment on the usage of the health promotion levy, and again, what is the department doing when it comes to the prevention of diabetes. I think we need to acknowledge the fact that we are not doing well as far as the prevention and control of NCDs are concerned, but we are kind of like moving. I think we are in the right direction. There are steps that we are taking that I think they will, at the end of the day, impact on the prevention and control of NCDs, diabetes included. For an example, I don't know how many of the colleagues saw the advert in the newspaper for funding, especially for NGOs that are in the NCD space. I think that was about a month or so ago. And as the department, we acknowledge the role that the NGOs are playing as far as the prevention and control of NCDs, diabetes included, is concerned. And for the department to end up arriving at that decision of requesting NGOs to submit their proposal, I think in a way it shows the department's commitment to improve the prevention and control of NCDs, diabetes included. And I think some of these things need to be acknowledged in platforms like this so that people can be aware of what the department is doing as far as NCDs are concerned. Thank you.
Thank you very much for those words from the department, and we're very grateful to have you with us here today for this webinar. Would anyone like to add anything? While I give you a moment, the panel, to decide if they want to add anything, I'll just let you know that there is a link that's been added by Kathy, who we heard from earlier, saying thanks that you can share links here. There is a petition for access to continuous glucose monitoring for children accessing care in the public sector. Please find more information here, and then there is a link to a petition. So if anyone is interested in that, please go ahead and have a look. I'm double checking. I don't see any more questions in the Q&A, and I also don't see any in the chat, but I'm happy to turn to you, Professor Goldstein, for a comment.
Thanks. I just a comment, and thank you to Dr. Setlare. Of funding towards NCDs is really way too low, and I think it just hasn't evened out. So we've seen how high the diabetes death rate is compared even to HIV, and yet the allocation of funding is much smaller. And I think that that needs to be really adjusted. And I think you guys are doing a great job with what you've got, but you need way more than that.
Thank you very much. Itumeleng, I'm not sure if you would like to respond, or okay, Dr. Pioti's hand is up. Please go ahead.
I would like to second what Prof. Su said. In all fairness, the department, or should I say the NCD department within the Department of Health, it's doing a lot of work. For example, the production of the National Strategic Plan was quite an achievement. We have endeavored to work hand in hand with them. We would like, as a partner, need to acknowledge that there is a tremendous challenge when it comes to staffing in that department. We believe that the department that is responsible for diabetes, hypertension, cancer, and the likes in South Africa shouldn't be manned by only 3 or 4 people. That's completely unacceptable. So this is a call really to the power that be, that this department should be capacitated. There should be much more people focusing on those dreadful conditions which are in the main preventable. And we need to see more resources, as Professor said, and we need to really see a national drive, a commitment. You can see, for example, Prof, like every time there's World TB Day or World AIDS Day, it's either the deputy minister or the deputy president who will be speaking. It's not often that you see the deputy minister or the deputy president speaking when it comes to diabetes, and that is a shame. We want to see that level of political commitment. We know we are at a place in this space where even internationally with the UN high-level meetings where they will be reviewing the commitments made globally for NCDs. South Africa is not doing well in all those metrics. It's important that we start seeing the level of commitment and political will that it deserves. Thank you very much.
Thank you very much, Dr. Pioti. I think that those comments are heard. They're not falling on deaf ears. Yes, Itumeleng, go ahead.
Yeah, no, thanks, Prof. I agree, colleagues. You know, there is a lot of ground to cover, but I think the step that the department has taken is a step towards the right direction, acknowledging that there is a lot of ground to cover. And I'm speaking under correction here. As far as I know, I have never heard of any country that support NGOs in the NCD space. But I'm speaking under correction. And I think this will be like, South Africa will be like the first as far as I know. And I think we need to applaud our country for that. Thanks.
Thank you very much. And on that note, seeing as we do not have any more questions in the Q&A or in the chat, I would like to hand over to the chair of the ASAF, Academy of Science of South Africa's Standing Committee on Health, Professor Lakan Ayo Yusuf. Thank you. Over to you, Prof.
Thank you very much. Yeah, I'm listening with so much interest. As we draw this important webinar to close, I'd just like to extend my sincere appreciation to all our speakers in particular, and also to the participants and partners for engaging so thoughtfully in the discussions throughout. We've heard the compelling evidence, personal stories, and of course, policy insight on the HPL, all underscoring the single urgent message that I hear. It's diabetes is not just a medical issue. It's a social, economic, and policy imperative for South Africa. The statistics are quite sobering. Diabetes is now the second leading cause of death, with millions undiagnosed or diagnosed too late, 67% pre-diabetic. Yet the message from today's conversation is still one of hope and action. We've oftentimes have, people have webinars that you leave without hope, and it's just all about, things are bad. But we've been able to hear a good balance from this webinar. We all acknowledge the tools, and through webinars like this, the collective will to turn around the tide. So let us take forward the call to scale early detection, invest in patient and provider education. As I heard, not just about education, but understanding, as Mr. Zuma said, and to ensure that our policies like the sugar tax work harder for public health. Although still from a very low base, quite sad to hear even allocations were not spent, very low. But I'm still glad to hear that the NDOH is now moving in the right direction, using the HPL more effectively. I must say, Vic Health and many other health foundations do allocate money from levies like this to NCD. So there are a lot of examples. Thai Health in Thailand, for example, also does that. And it's quite significant, and I think we should learn from those best practices. Let us all then commit to advocacy. As some of you would know, I'm quite passionate about that, and I'm also glad to see Patrick and his passion for it. Don't worry, we'll get you Deputy Minister and Minister at the next event. So we need definitely to commit to advocacy that is innovation and data-driven, equity-focused and people-centered. That's what I hear. So again, I want to thank you all for being part of the conversation. Let us not end it here. Let it mark the beginning of a coordinated, because I think the word is coordinated, because pieces of actions here and there does not give us the efficacy that we need to move forward. So we need coordinated cross-sectoral action to prevent, manage, and ultimately reverse diabetes epidemic in our country. And together we can build a healthier South Africa. So I'd just like to again say thank you and take care. Enjoy the rest of your day.
Thank you very much
Thank you,
for those closing remarks. And yes, thanks to everyone for joining and to the panel. Take care, everybody. Until next time.